So we've got some really awesome people here today. Dr. Jennifer Janelle is kind of the ringleader of a group of multidisciplinary folks from over in Gang, is that that Dr. Blue and I have had the pleasure of working with for the last 12 months? Yeah. As part of a grant out of Vanderbilt University. And so I'm not going to steal her thunder and talk about that at all, but what I will say is that this is the first time that we've had a thematic focus for what we're doing this year, and we're going to be doing it for the next couple of years. And that thematic focus is HIV, which we're really excited about. We think that there are a lot of opportunities for not just student learning, but our own learning associated with that. And so what we're going to do tonight is allow Dr. Janelle and her team to talk with us a little bit about some kind of contemporary things about HIV and AIDS, and then we'll talk a little bit about the case. We may not get all the way through it tonight, but we'll cover the high points, and this is the case that you guys will be teaching about in 8 days. And then what we'll have a chance to do sometime next week, and if you can't make it, don't worry, because I will come and find you and talk to you on the phone. Do whatever I need to do to make sure that you're prepared 8 days from now for our first session. Does that sound pretty good?
Sounds good to me.
All right, so what we're doing tonight, Dr. Janelle is going to kick us off. Dr. Blue is going to talk a little bit, and then we've got Debbie Sestaro. Can I say that right?
Yeah.
All right. Who's going to run us through a game. We've got Joanne Orrick, who's going to talk to us a little bit more about HIV in depth. We're going to talk about the case, and then hopefully, if we play our cards right, we should have, in theory, 10 minutes left for you guys to ask questions when we're all done.
And just to mention, Joanne's going to be right before Debbie.
Oh, we're going to set that up?
Yeah.
Okay.
Yeah. Okay. So I'm super happy to be here. For those of you who don't know me, I'm Jennifer Janelle. I'm in the Department of Medicine in the Division of Infectious Diseases and Global Medicine. And my main area of focus is HIV. And last year, HRSA restructured the AIDS Education and Training Center grants, and Vanderbilt is now the head of the Southeast AIDS Education and Training Center, and with that new RFA came recognition that a lot of the efforts that we've done as an AETC in the past where we focused on prescriptive providers was really coming too late for a lot of providers. We recognize that by the time folks are already out in the workforce, a lot of them have already decided that HIV isn't something that they're going to focus on. And so one of the focuses of the grant this year was to really try and attract students to interacting with folks with HIV in a better way, being a little more culturally competent, working in teams, and trying to provide really excellent care, whether it be in primary care, dental care, whatever their area of focus ends up being, because we still know in this day and age there's a lot of stigma, even in the healthcare system, towards people with HIV. Another issue that's happened is over time, there's been a decrease in the HIV workforce, and so part of this effort is to try and increase the HIV workforce, starting with people in their very early years of training in health professions. So one of the program requirements for our grant was to train the faculty of health profession schools, graduate departments, or other programs to better equip them to teach their students to address the healthcare needs of people living with HIV through interprofessional education and collaborative practice. And we were one of the few schools in our area that actually had an existing IPE program, which I was so excited about. A lot of places are actually having to create their IPE program through this grant. And so it was nice to have already a foundation with people experienced like Amy and Eric. It's really been a huge advantage for us. So it's been a real collaboration because we have our ideas about HIV and healthcare and motivational interviewing, but inside the structure of IPE, Amy and Eric really know all of that the best. So hopefully you'll find that this is going to be a really good collaboration, a really interesting journey for you guys with this case series. So I thank you guys for coming tonight. I know the rains and the storms are a little bit exciting, so thanks for coming and for your attention, and I'll pass the baton to Amy. Amy Blue.
I think I'm supposed to stay up here. Again, thank you all for joining us. And thanks, Eric and Jennifer, for the great introduction. Sort of big picture, some of you have worked with us with IPLH, Interprofessional Learning Healthcare, in the past. Some of you may be new to this. This is part of our overall UF Health Interprofessional Education Program. In the first year, our students get a phenomenal experience with an award-winning program. If you're not aware, our Putting Families First program has received a national award. And we know a couple of our groups may work with some families in which HIV/AIDS is a health issue. But Eric and I, and working with Jennifer and her great team, and we'll do introductions in a minute, thought that for our second year experience, or the second year required IPE experience, IPLH, that this would again be an opportunity to touch about 700 students in terms of in-depth knowledge around HIV and AIDS. And we have decided to create a patient. You'll be introduced to Morgan Rivera later on today, this evening, and we'll talk a little bit later on then what our big picture plan is for that. But essentially for the 3 IPLH sessions, students will be focused on Morgan, her care, her struggles with HIV/AIDS, going through the healthcare system, and we'll be having students think about themselves as an interprofessional team addressing her care needs. So this does, as Eric has already alluded to, we're shifting to a kind of a content focus, but some of the other learning that we have occur in IPLH, such as teamwork, patient safety, thinking about trauma-informed care, and we're going to be throwing in some motivational interviewing. Those things are present. So we can talk about them a little bit later on. So we were excited to bring something new into our big picture IPE offerings for our students. Thank you, Jennifer. I think you're right. Of the institutions who are working in this region, we kind of had a ready-made infrastructure to bring this in. So let's do some introductions real quick, because Eric and I have had the pleasure of working with a wonderful team that you all don't know everybody yet. So do you want me to start with you, Taryn? As an introduction? So I would just say introduction, college or program, anything else people want to know about each other right now? Who's bummed the campus is closed on Friday?
Not the sad face.
I know. Go ahead.
Hi everyone, my name is Taryn Buckley. I'm the project manager with the North Florida AIDS Education and Training Center.
So we'll then go.
Hi, my name is Debbie Siefer, and I am I'm an educator and training specialist, I think, is what my role is. I'm just happy to be here with you all.
I'm Sarah Reed. I'm a lecturer and program director in the psychiatry department.
I'm Kristen Matrone. I'm a first-year fellow in the Division of Neonatology.
Jim Busher, I'm a third-year resident in general pediatrics.
I'm Joanne Horrick. I'm a pharmacist with the North Florida.
I'm Linda James. I'm the program coordinator for the North Florida AETC.
I'm Nicole Stetton. I'm a second-year PhD student in public health social abuse.
I'm sorry, I'm Cindy Wilkes. I work for the Putting Families First program with this located.
So before we begin the more official part of this, and maybe it was made clearer earlier, we're recording this one for those who might not be able to attend this evening, but also sort of our collaborators on the grant kind of want to see what helped faculty development. So this will be an interactive session, but some more of the formal presentations we'll definitely want to be capturing. So, anything else, Joanne or Eric or team you would be thinking about? Linda? Okay, so I'm going to pass the baton to, is it Joanne?
Joanne,
Okay.
next.
Well, it's great to be here. I'm actually based in Tampa currently. I was going to say a former Gator, but once a Gator, always a Gator, right? When I walked into this room, I had not been probably in this hallway in over 20 years. And I remember doing a pharmacy school project outside of the informatics lab 23 years ago. It's great. Everything looks so different. Yeah, it's the same, because I do think the couch that's out there is really the same couch for us. So today, or this evening, I'm going to be providing a brief overview of HIV and AIDS. And just so you're aware, this information that I'm about to present is information that the students have been provided. Oh, I hope these timings are not on this slide. Information that the students have been provided in their resource toolkit, I don't know, what on the Canvas for the course. So we wanted to just spend a little bit of time tonight providing a brief overview for everyone. So here's the objectives. First, I'm just going to discuss some important points in the HIV/AIDS timeline in the U.S. I want to, I'm going to stop, and if someone can help me figure out how to take these timings out, because I think it's going to do that. I saw it. I took everything out.
You said, yep.
Okay. Sorry about that. Okay. Okay. So I'm going to, yes. I'm going to be providing a brief overview of HIV and AIDS. So first, I'm going to start with discussing some important points in the HIV/AIDS timeline in the U.S., and then describe the Ryan White HIV/AIDS program, the National HIV/AIDS Strategy, and the HIV care continuum. Briefly discuss some of the epidemiology of HIV in the U.S. and Florida. Describe recommendations regarding HIV testing, and explain the pathogenesis and natural progression of HIV infection. So HIV was first reported in the MMWR, Morbidity and Mortality Weekly Report from the CDC in June of 1981. And at that time, they reported 5 cases of pneumocystis pneumonia, which was is a pneumonia that really only occurs in people that have very weak immune systems. And at that time, they didn't know what was causing this, but did certainly identify that there seemed to be this apparent increase in this pneumonia occurring, and it was apparent that these folks had weakened immune systems based on some lab tests that they did. So this was in 1981. At that time, unfortunately, because these initial cases were in gay men, at this time, AIDS was being referred to as gay-related immunodeficiency syndrome, or GRID. And unfortunately, that is because these first reports were in gay men. The next year, they were able to link HIV to the blood supply and identified that it definitely was a bloodborne pathogen. A few years later was when the first HIV antibody test was approved. And in 1986 was the first time that they agreed on the name. They identified the virus, and they agreed on the name of human immunodeficiency virus, or HIV. The first antiretroviral agent was approved in 1987. This is Zydavidine, or AZT. It's still a medication that we sometimes use today, although we now do more commonly use other agents that don't have as many side effects as this medication. And in 1990, Ryan White passed away, and I'm going to discuss briefly Ryan White in a moment. And the Ryan White Care Act was passed during that time as well. So in 1995, this was a big time with respect to treatment for HIV, and I've really selected just some highlights from the HIV/AIDS timeline. You can go online and see additional highlights, and of course I focused a lot here on some of the highlights related to the treatment of HIV. But they approved the first drug that is in the class of medications called protease inhibitors, and at that time, then it became standard of care to use 3 different medications to treat patients that had this virus. Prior to that time, patients would receive one medication, and then as other drugs became available, they'd get 2 medications. But this was the first time we really had very highly potent medication that was very strong at decreasing the patient's virus level. And this became termed highly active antiretroviral therapy, or HAART. And that became standard of care in 1995. A few years later, the CDC released their first guidelines for treatment of HIV, and at that time they recommended starting therapy early. And it was basically, we looked at 2 main markers: the CD4 count, which was a sign of the patient's immune system, their CD4 count level, and their viral load was a sign of how active the virus was or is. So the higher the viral load, the more active viral replication is going on, and of course the more quickly the patient's CD4 cells or immune cells are being destroyed. So at the time, they recommended starting therapy early. And then a few years later, we had resistance testing become available, and this is a key component to treating patients with HIV. Now we can actually test the patient's virus to see which medications their virus may have developed resistance to, so we can use these results to select the most appropriate medications for the patients over time, for an individual patient, over time. And then over time, the guidelines changed and the recommendations were to start therapy later, and we waited until patients' CD4 count got lower before we started therapy. And this is, strange to think that there was a time when that's what we did, but this was mainly because we had a lot of medications at that time that had a lot more toxicities and long-term toxicities, more toxicities than the medications that we have today. And we did not have a lot of data, or really did not have good data at the time to tell us that it made a difference to treat patients earlier. So it was always a risk-benefit analysis of, do we start therapy now or do we wait? So the guidelines at that time said wait, and so we waited until patients had lower CD4 counts before we started them on therapy. The standard of care now, since 2012, has been that antiretroviral therapy is recommended for all patients with HIV infection, regardless of their CD4 count or viral load, because we do know that they're going to do better the earlier we treat them, and we also know that the use of these medications to suppress the viral load is an extremely important component of HIV prevention, of preventing transmission to others. So it's a really important aspect of getting a handle on the spread of HIV in this country and around the world. In 2006 is the first time we had what is called a single tablet regimen, and we have probably 6, I'd say, single tablet regimen options available now, which is basically someone takes 1 pill once a day, and it has all of the antiretrovirals, 3 antiretrovirals in that 1 pill, which is just amazing because, back in the late 90s, the number of pills patients had to take and the size of those pills was just astounding. So this, I just wanted to show you to just make the point that HIV is now a treatable chronic illness. When we first were recognizing HIV, we didn't have a lot of therapies for patients, and so patients were dying, pretty quickly after they got diagnosed. So just to go to here, looking at the 12-month mark, if you look at someone who got diagnosed in 84, 85, less than 50% chance, less than 50% of those patients were alive after their first AIDS-defining illness was diagnosed. And if you look at 2000, which is the latest I've been able to find these information from the CDC, about 80% of people were still alive. And this is really attributable to the medications that we have and the fact that we're able to now get this virus under control with these medications. So Ryan White was a boy who was diagnosed with HIV in 1984 at the age of 13. He was one of the first children with hemophilia to be diagnosed with HIV. And he got the HIV through blood transfusion. And he experienced a lot of stigma and discrimination because there was a lot of fear, and there still is, unfortunately, a lot of stigma and discrimination today. And he was prevented from going to school. His school in Indiana, everyone was, parents, students, they were afraid of him going to school because he had HIV, and he had to fight to be able to go to school. So he and his mother became advocates, and his mother still is a big advocate for HIV. And the Ryan White Care Act was passed and named after Ryan White. It was passed in 1990. The Ryan White Care Act funds, it helps approximately 52% of people that have HIV in the U.S., and it supports a comprehensive system of care that helps people that are either uninsured or underinsured to help these patients remain in care, remain on antiretroviral therapy. Because this is a major public health issue, we need to get patients in care on therapy with undetectable viral loads in order to get this epidemic under control and to prevent further cases of HIV. The Ryan White Care supports a lot of different things, including the AIDS Education and Training Centers, which is the program that we're working under. I just want to briefly review the National HIV/AIDS strategy. This was first released in 2010, and this strategy is basically meant to provide a comprehensive and coordinated effort at impacting the HIV epidemic in the United States. And it was first released in 2010 and updated again in July of 2015. So these are the main goals of the National HIV/AIDS strategy. And first, the goal is to reduce new infections. Another goal is to increase access to care and improve health outcomes. Next is to reduce HIV-related health disparities. And finally is to achieve a more coordinated national response to the HIV epidemic. And there are many indicators within this National HIV/AIDS strategy, but here I'm providing just a selection of these indicators. So one of the indicators is to increase the percentage of people aware of their HIV status by 90%. So we need to get people tested and diagnosed with HIV, and also decreasing the number of new infections by at least 25%. And then increase the number of newly diagnosed people linked to HIV medical care within 30 days of their diagnosis to greater than or equal to 85%, meaning once they get diagnosed, we have to get those patients linked to care, in care, seeing a provider that is managing their HIV. And then increase the number of patients retained in HIV care by at least 90%. Just to briefly review a little bit with respect to the HIV epidemic, this shows the rates of adults and adolescents living with HIV infection. This is from the CDC year-end 2013 data. And I think, what's important is important to realize is that in Florida, we have very high rates of HIV infection. We have one of the highest rates in the country. Actually, was it last year? Was it 2014 or 2015? 20. Okay, yes. In 2014, we were the second. We were up to number 2 for number of HIV diagnoses. So that's not, we want to be number 1 in football at the University of Florida. We don't want to be number 1 in HIV or AIDS cases, but we have, this shows you in the maroon color here, some of the highest rates, and this is 600 per 100,000 population. So looking at the transmission category, this has changed over the years with respect to the percentages of AIDS classifications and adults with HIV. Among adults and adolescents with HIV infection by transmission category. So in 1985, when this information was first being gathered, the highest percentage of cases were related to male-to-male sexual contact. Excuse me. It still is the highest percentage, but you see that heterosexual contact over the years, the percentage of cases where heterosexual contact was the transmission risk identified, increased over time, and this has now leveled off. And injection drug use declined over time, and it appears that it may be increasing a little bit now. But this just shows you the changes in the transmission category and the percentages over time. And there's also been changes with respect to race and ethnicity over time. So the percentage of diagnoses in whites was almost 60% initially, and that has it steadily declined over the 90s and now has leveled off, and there were increases in the Black and African American population, relatively stable but slightly increasing in the Hispanic Latino population. So this was information actually that was presented earlier this year at a national HIV conference, showing the estimated lifetime risk of acquiring HIV in the U.S. The overall lifetime risk based on this CDC analysis is 1 in 99, but there are a lot of discrepancies by race, risk group, and also geography. So if you look, even though it's 1 in 99 overall for the U.S., it's 1 in 54. So 1 in 54 people in Florida have a lifetime risk of acquiring HIV. So to go dig down a little bit further by transmission group, MSM is men who have sex with men. There's a 1 in 6 lifetime risk of acquiring HIV. And looking at this by race and ethnicity, African American men, a 1 in 20 risk of acquiring HIV. And then I think this is pretty astounding that African American MSMs have a 1 in 2 chance of acquiring HIV in their lifetime. So I just want to briefly review the HIV care continuum. This looks at the different stages that a patient may be in with respect to their stages of their being in care and on therapy. So first we see when patients are first diagnosed, then we need patients linked to care. Engaged in care means they've had, I think it's 2 medical visits within the prior year to show that they're engaged and retained in care. And then on antiretroviral therapy, and then with a suppressed HIV viral load. So obviously the goal is to get people diagnosed in care, continuing to maintain care, and continuing to maintain a suppressed HIV viral load. Because if their viral load is suppressed, they are going to be unlikely to transmit the HIV virus to others. So in the U.S. in 2011, this just shows you estimated 86% of people living with HIV diagnosed, so about 14% estimated to be unaware of their infection. Only 40% engaged in care, only 37% prescribed antiretroviral therapy, and only 30% with viral suppression. So a lot of room to improve that. And this I just wanted to show that basically the people most of the people that did not have viral suppression are people that were diagnosed but not engaged, diagnosed but not in care. So it's extremely important as healthcare providers that we recognize this, that patients need to be in care in order to get their virus under control. So routine screening for HIV infection has been recommended by the CDC, and basically this is to have routine screening for HIV for all patients between the ages of 13 and 64, all patients in that age group, or you may go outside of that age group. I think we've certainly seen a number of patients diagnosed that are older than 64, so it's kind of an arbitrary cutoff. Should be screened for HIV infection. This has been recommended by the CDC since 2006. And I usually, when I'm giving this, including this in a presentation to healthcare providers, I ask how many people have been offered an HIV test at any of their recent primary care visits, and I usually get a very small group of people that have, the minority of people have been offered an HIV test. I can tell you, I was not either until I was pregnant last year, in which case I was offered an HIV test at that time, and if my OB didn't offer it to me, I was going to tell them, you need to offer an HIV test to me. You need to offer me an HIV test, and provide a little education on why they needed to do that. But it is something that needs to be done. And as of 2015, Florida now allows for what's called opt-out screening. It's been recommended by the CDC since 2006, opt-out screening. We finally have that as an option in Florida in 2015, where written informed consent is not required for HIV testing. It's basically inform patients that I'm going to be testing your blood sugar for diabetes. I'm going to be doing, this, and this test, and we're also going to be doing an HIV test. And the patient has a right to decline it, but it's not this active, we need patients to sign to do this test. The HIV tests have improved over time with respect to how early we can detect HIV infection. And so this just shows you here the first generation antibody tests. There was a much longer time. This is the time since infection when the virus can be detected by these different testing methods. So when we first had the antibody test available, 55 days or more would go by before we could detect the antibody. So now the standard of care with respect to HIV testing is a fourth generation antibody test combined with an antigen. So we are able to detect HIV much earlier. I'm not going to go into it in these slides, but they have a new CDC algorithm for how the testing should be done, and what is done with the tests, and depending on the result, what different tests are done to determine if the patient has HIV. But we still, if we have someone who has it suspected of having acute HIV, it's not a zero, it's not automatically that, they got infected yesterday and they test, positive even with the current test the next day. So if someone does have suspected acute HIV, and if patients do have symptoms of acute HIV, the symptoms can mimic a flu-like syndrome, except patients do not experience a runny nose usually with this. So, but it's other symptoms that may kind of mimic the flu: fever, malaise, rash, lymphadenopathy. And if patients are suspected of having this, then they recommend checking an HIV viral load to try to detect the HIV earlier. So HIV can be spread through sexual contact, injection drug use, pregnancy, during childbirth, and also through breastfeeding. So women are instructed if they have HIV that they should not breastfeed. And also there can be infection through occupational exposure, needle stick injuries, and such. HIV is not spread through air or water, insects, mosquitoes or ticks, saliva, tears, sweat, casual contact like shaking hands, drinking fountains, and toilet seats. So these are not ways that HIV is going to be spread. The highest risk sexual behavior is anal sex. So I'm not going to spend a lot of time reviewing this, but this just shows you the HIV life cycle. And basically, the HIV virus is basically, in order to replicate in the individual, it has to take over their CD4 cells in order to produce more and more virus. So the HIV virus is an RNA virus. It initially binds to CD4 receptors, and then there's fusion with the CD4 cell. And then an enzyme that it has called reverse transcriptase is used to make HIV DNA, which gets incorporated into the host cell through an enzyme called integrase. Then there is replication that occurs, so it's basically taking over the CD4 cell to make more and more HIV viral particles. And then assembly and maturation occurs. There's an enzyme that's involved there called protease, and then the protease enzyme is involved later on in the process, where it's necessary to cleave up some of the larger proteins into the smaller proteins to make a fully functioning virus. But the point being that we have medications that attack various steps in this process. and we have medications from several different classes that are used to combat the replication and combat the infection. So what happens if someone has HIV but they don't go on therapy? So this just shows you the natural progression of HIV, and this is showing in blue the CD4 cells or the lymphocyte count, and red the HIV viral load, which we say RNA copies per milliliter of plasma. And so basically, there's this initial acute phase that occurs, and this is where the person may have symptoms. They're having a lot of viral replication that is going on, and a lot of attacking of the CD4 cell that's going on at that time. And a lot of times, unfortunately, the acute syndrome, even if it does occur, goes unrecognized, and people don't seek treatment necessarily during that time. There is a very long and varied clinical latency period, and that's one of the big problems with this virus is that patients can go for years without having symptoms, but they can still transmit the virus, of course, to others. And during this period of time, and it varies from individual to individual, it really is just going to depend on the patient's viral load set point as to what we call their set point as to how long that latency period might be. Someone might get infected and have a viral load set point, which is where their virus kind of sets out after their body kind of does what it can with it. Some people can have a viral load set point of 1,000. Some people can have a viral load set point of 2,000. Others can have viral load set points of hundreds of thousands, 1 million. And as you can imagine, if someone has a viral set point of 100,000 or 1 million, they're going to have a lot more virus around attacking their T cells a lot more quickly. So they're going to have a shorter latency period. And over time, they can develop what we call opportunistic infections and diseases. And these are what eventually will cause the death. It's not the HIV virus itself. It's the other complications that they're getting from having the HIV virus. So this just shows you some of the infections that we see. As the CD4 count declines, we see more and more different types of infections that can occur. And we have some medications that we can use, like if a patient's CD4 count falls below 200, we prescribe an antibiotic called Septra or Bactrim that's going to prevent them from getting pneumocystis, Jirovecii pneumonia, or PCP. It also prevents them from getting toxoplasmosis. Unfortunately, we don't have the ability to prevent every possible opportunistic infection or disease from occurring. It wouldn't it's not necessarily beneficial, and we don't necessarily have medications that can prevent everything that the patient might be at risk for getting. So I know that was pretty quickly, but we wanted to make sure we had enough time to move on to the interactive part with Debbie. And we have, did everyone get copies of these in their handouts? Did they get copies of this? Okay. So probably you'll be emailed a copy of this, and we have resources listed here, different websites. And again, these are the resources the students have been instructed to access for the first session as well.
They'll have a copy of this one.
Okay, great. And I will go ahead and, if you have any questions, I know we have time later on for questions, but I'm happy to take some questions now if anyone has any. All right, well, thank you very much.
Thank you for doing such a good job on the 2020 vision, because I don't have to go through all that. You did a great job. Thank you. The strategies, I'm going to spend time speaking directly about stigma and how that affects everybody. And my name is Debbie, as I introduced myself, and I'm a real interactive kind of person. I taught psychiatric nursing in the U.S. Virgin Islands and lived in an area where the Caribbean, that is number 2 in the world for new cases of HIV incidence, behind sub-Saharan Africa. So when I got there, I really didn't know HIV, but I learned it very quickly because of that incidence and because of the terrible stigma that I saw. So to begin us out here, let me pull our slide set up, and I know that that's me. Yes. So the title of this is Identifying and Mitigating HIV-Related Stigma in Healthcare Settings. And I think that really affects us as we are teaching our students because they're coming in with different knowledge, maybe insufficient knowledge. Maybe they come in with a great deal of knowledge. I had two students myself that were HIV positive in one of my classes. So again, you never know where that's going to come from, and so being aware as the professor and knowing where your resources are. So I think Jillian's program and presentation was really excellent to get us all on the same page. I don't have any disclosures to make. I don't own anything. I don't barely own my car right now, so I'm doing pretty well, but I always mention that. The agenda is to do a little bit of an overview, to have some interaction so that you can experience some things, and this might be an opportunity for you to experience some things with your students. I'm going to run through the initial game, I'll call it, very quickly, knowing, please, that I take a lot of time with this initial game, and I'm only speeding it up because of time and because of the fact that I'm sure you will be understanding where I'm coming from with the experiential part of it. So I don't normally run through it quite this fast. It might even take an hour and a half to run through the initial game that I'm presenting to you. So let's do this. Nothing's there, so that we're going to play a game. What I'm going to have everybody do is I'd like everyone to stand up, and somehow we're going to form a circle. And just side by side this circle. I don't know where the circle is going to go, but I need an open space. Normally I would move furniture, but we're not going to do that. So if we could maybe come closer and bring the circle up this way, that's great. Yeah, no worries. Okay, so the way this goes is I need everyone's, okay, you know how you go to the, you're in the airport and you sit on the plane and they tell you that, or they ask you if you're in the get out of Dodge section, you're in the exit section, right? They'll ask you, we need a verbal confirmation that it's okay that you do this and that you're sitting there. So I need from everybody just one by, that it's okay that I touch your shoulder and that you're comfortable in playing a game where you may be challenged with feelings that you've never had before. So I do this with my students just to let them know that we need to get that verbal okay to be touching a patient who may have experienced had some sort of violent issue or something happened to them. So touching on the shoulder could bring up some issue for a patient that could be very difficult. So I teach that right in the beginning. So if everyone just go around, it's okay I touch your shoulder, and two, it's okay that you talk about maybe some uncomfortable feelings that you may be having.
I just need to stipulate that you're being recorded, so you need to speak as loud as you can since you're away from the table.
Thank you very much. Are you hearing me pretty well, or was I fading out on you?
This is probably not something we probably do.
Yeah, I know.
I think it's okay.
I think it's okay. Okay.
If we could stage it later.
Okay, great. Okay.
So yes and yes.
Yes, okay? Yes?
Yes, yes.
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 Yes. Yes, yes. Yes. And then what we do is we get library books, we do other things, we make that work. Okay, so how we're going to start is, I'm going to have, this is the way it's going to go, I'm going to have everyone, not yet, close your eyes, and then I'm going to quietly touch someone on the shoulder. And that person that I touch is going to be, for all practical purposes of this game, infected with HIV. Okay? That person should not share the fact that they've been touched. And when I ask everyone to open their eyes, I want them just to be looking out and acting just normal, regular, even though you know that you have a virus. Okay? But no one else is to know this information. All right? Then there's going to be another step, and this is going to be followed by, I'm going to ask people to have social interactions. And our social interaction will represent actually a sexual interaction. So I'm going to have you shake hands with each other. And I'm going to tell you exactly who I want you to shake hands with. And when you shake that person's hand, if you are the person that's been touched on the shoulder, then I want you to scratch the inside of the person's hand. Not to cause trouble. So I want everyone to do this to yourself. have a little finger in there and you go, ooh, ooh, you know, it's just not a shake. It's a little bit of a, I'm not saying go for blood. I'm just saying do a little bit of a scratch, okay? That will mean that you have transferred the virus. We don't know if you're positive, but you have now been at risk of a transfer of the virus. You are at risk at this point, all right? And then I'll keep giving you instructions, but those are the two things you have to know how to do it in order to play this game. After that, it's really just about answering the questions that I'll be throwing out at you. So is everybody good? Okay. So the first thing I need everyone to do is to close their eyes. Alrighty, everyone can open their eyes. Alright, we're all back, and we're now, I would like to ask what that felt like having me walk around and not knowing if I was going to touch you or not. How did that feel? Thank you. Thank you. Anybody else? Another feeling? Feeling word? Curious. Wondering what was going to happen? Okay. Anybody else?
Sensitive, because I could actually see your shadow moving, so I was sort of sensing your movement.
Thank you. I was wondering, because I made some absolute noises towards the back. Oh, wow, where's she going? And I was wondering if anyone picked up on that, so thank you. The next thing I'm going to ask is, we're now all going to get socially interactive. And what I'd like you to do is eyeball, now I can't play because I'm obviously facilitating, but I would like you to get eye contact with someone that's directly across from you. Now, usually could be 2 or 3 people. You know how you do when you go, I'll see you in the back. You know how you do that look to people? See if you can find someone. You're going to give them that look like, okay, we're going to shake hands. All right? Does everyone have a sense that there's someone there across the way they're going to shake hands with? Go shake your, okay, no, that's good. Is there anybody else? Okay, does anyone, already in on? Are we at on? Okay, we got it. All right. So now let me just say that the person that has been touched by me needs to be the only one to scratch. All right? So there will be one person that's going to get scratched, and I don't want you to tell anybody that you got scratched. Okay? And you're going to return to the spot that you came from. Everybody follow? Questions are welcome at this moment.
Everybody's returning back.
Everyone's going back to their spot, but they're going across the circle to shake hands
We
with
have to
someone.
cross.
Right, you have to yes, as you can see, a little living room work is done before you to this day, but, okay.
But what if the person whose hand you're about to shake goes to shake someone else's hand?
Well, then that's when you just wait. Yeah, right, you just, you wait and see if there's anyone else that didn't get a handshake. So I will shake your hand. I will shake your hand. You will not leave your vessel to shake your hand. Okay, everyone feeling safe? Okay. 1, 2, ready, go to find your friend and take your hand.
Which way are you going?
This way.
Shake
Good
one
to
or
see
two,
you.
just one
All
person.
right.
Well, you grow. Right.
We're kind of just,
Yeah, she can shake 2 people. Okay, shake 2 people. No worries. And does anyone need me to shake their hand? Is there anyone feeling left out?
I got a handshake.
There you go. Okay. So now we know that the person that I touched has scratched at least one person's hand, maybe 2, right? If someone shook 2 hands, I wasn't monitoring everybody's behavior, okay? And that doesn't happen in real life, right? There are not people watching you all the time. All right, so how did that feel? What did that feel like?
Waiting for the scratch.
Right, anticipation, right? It's a little like relief or not relief. Right. So there's a little more anxiety and some.
Poker player, that was.
Well, now we're going to do it one more time. We're going to do it one more time. And I want everyone now to go to the person to their left, and I'm going to shake people's hands here now, too. Go to the person to your left and shake their hand. So what does that mean? Someone's not going to have someone, so I'm going to have to shake someone's hand. So you turn to the person to your left and you shake their hand and you turn back. Okay?
Well, but if everybody's, wait.
Oh, right.
Yeah.
Right. Yeah, it's good. So, right. So there you go. Right, there we go. So there you go. Perfect. Everyone stay poker. I'll stay poker with Jack. Now, with that being said, I want everybody, well, first of all, who was the initial person I touched? Who knows that they're positive? Okay. If you'll come up and stand next.
That's somebody over here.
Yeah. All right. So now I'd like everyone who was scratched to stand right here. So who has? Okay, everyone. Because she's, so you're going to scratch too? Okay.
I think we were supposed to get infected and we didn't.
Okay.
You got lucky.
All right, so
Whoa, and never happened.
no scratch, no scratch, no scratch, no scratch.
Yeah, that was my anxiety, if I scratch appropriate.
Right. And normally I do when we ever practice scratch.
Well, trained on scratch.
I thought was I was scratched by her, so I was supposed to scratch her,
Yes,
right?
if you were scratched.
Shook my hand, so I scratched.
Yes,
Okay.
absolutely. Right, exactly.
It's okay.
So it's okay, everyone's getting the idea how this works. Okay, so for those people in the outside of the circle who aren't sure that they were scratched or didn't get scratched, or how are you feeling? How are you feeling? Relieved. Yeah, that's normally what people will say. I'm relieved. I feel like weird though that I'm way out here and all these people are in the middle, but yes, relieved. Any other feeling words or thoughts? Right, no, I think you.
Did we do it right?
Right, when you see so many people, you think, I must have done something wrong. Now, the people on the inside who were scratched, what is your feeling right now? Holy cow. Yeah.
It's kind of scary to think about how it didn't take much.
It didn't take much, and it happened. I always tell people, it happens quickly. It's easy to have sexual relations, but it's so hard to talk about. And so that's really important for people to recognize and how quickly it can happen.
I have guys that have sex with 30 people
Yes,
in a
yes.
night.
Exactly.
And just think about what
Right. So right now, the only person. It is, and right now, everybody, you know that you're positive because I told you that all of you don't know you're positive. Would you like to know? Oh, okay, you would, sure, oh yeah. Now, other people haven't heard. There are some people that don't want to be tested. They do not want to know. Is there anyone that's feeling like, I'm not sure I really want that experience right now being tested? Because you don't have to be. I'm recommending it as your provider who just saw a wonderful presentation by Dr. Warwick, but I'm not going to force you to have it because this is informed consent. I'm telling you, I would like you to get tested. I think it's the best. You've had unprotected sex, but I can't make that decision for you. You can decline. So what are people feeling? You said yes. You said yes.
Absolutely.
Okay. So you may not open this yet. Okay. Those are your test results. Test results. You yes. We would like to do it. Would you like it? Would you like your test results? Okay. Cannot open it yet. We would like your test results. Test results. Yes. And test results. Okay. And normally what I do is even put another. When I have a huge class, or sometimes I'll have like 50 nursing students in my class. My outer circle, I'll say, it's your lucky day. 3 of you have been tested without your knowledge. And I'll say, 1, you were just incarcerated, and they tested you on your way in. You probably don't remember. There was a lot going on that day. Then I'll say to someone else, you were pregnant, and you were found on a boat from Haiti, and you came over, and we tested you, and you probably did not know. And then usually I'll say a third person, and I'll say, you came into the ER, and you broke your leg, and you probably don't remember because it was so painful, but we had a little tester in there, and they asked you, and you said, sure. But you don't remember it because you were in so much pain, okay? So I usually involve some people in the outside circle as well, so that we don't disengage the outside folks. I go, oh, wow, I can be tested.
I already know my results.
Yeah, right. Give that to someone else. Right. Okay, so what is it like waiting? Did you really want me to be quiet?
I already did it.
Yeah, you already looked.
I was gonna tell on you, but then I thought that might be inappropriate.
You see how that is? Some people biting at the bit. So wait, okay, who would have to wait for their test results?
Everybody.
Well, unless you have a rapid test, as Joanne was sharing with everyone, you have a rapid test, you may get your results and within 20 minutes, you may have results.
Still a long time.
But that's a long time. What if right, and it's not confirmed. Now, what if you go and you have the blood drawn, but they say, well, you'll find out in a week? Is that a long week or what? Maybe some people don't even want to come back at that point because they've worked themselves up. So again, thinking through what this feels like, this exercise really helps in that. Even if it's just for a minute, even if it's not real, I know when we play these games, you try to put yourself in as real a situation as you possibly can. And I see you thinking really hard.
I'm just thinking, even with the rapid tests, there was a time, I don't know if it still applies, 'cause it's been a while since I've done this, but there was a window that you had to go back and get retested. Even if you came back negative, if you were still engaging in the risky behavior, you were encouraged to come back and get the test.
They might say 3 months.
So that's still the
With those rapid tests, yes, it is.
Well, then you have a higher window of when it can even detect or to pick up versus like the new age, which is 11 days.
Yeah.
So your window is much further out than where you've been done.
So people doing home testing, those tests are really not accurate if you have been recently, exposed.
Isn't the Clearview rapid, isn't that immediate even though it's not confirmed?
No, it's not a fourth generation.
But they know there's a 4-year.
You'll determine it.
Right, exactly,
Yeah.
right.
So what about false positives? Because 21 years ago, pregnant, I said, sure, and my husband was like, no, you shouldn't have said that. There's a high false positive rate. And I'm like, so what about false positives now?
And it can happen.
And there's false positives for the screening test. And there's false positive, when you go through the entire diagnostic algorithm, which involves the fourth generation antigen antibody assay, and that you can have false positives, right? If you test a lot of people, there's going to be people that are going to test positive on that when you go through the entire algorithm will end up being negative. That initial ELISA is not perfect. So then you go through the multi-spot, which is a HIV 1-2 differentiation assay. That requires the antibody to be present. So you get your first ELISA, you don't know if it's the antigen or the antibody that's present. So you don't know if you're acutely infected or if you're chronically infected.
And how long does it take? The antigens weren't occurring until like 4 or 5 weeks, right?
No. The antigen comes up right at about 11 to 17 days. And then the antibody is longer. It takes longer, right? A couple of weeks. And then the HIV viral load will be positive just a little bit before the antigen. So if you have a positive initial screen, the antigen antibody assay, a negative differentiation assay, which is an antibody only. Then if your viral load is positive, that means you're acutely infected. So that's kind of how we know now. Now Debbie just mentioned a test called an Alere determinant. That's a point of care test. And it's really awesome because it has stripes on it. And you can actually tell which band is causing a positive test. You can see if somebody has a P24 antigen because that disappears after a couple of weeks. And so if that's present, then that person's acutely infected. So, but that test, it's not widely available, and it is not what people are using for rapid testing everywhere today. What they're using today is third generation, sometimes second generation, which is, really except people are chronically infected. And cost? Because cost, yeah. Cost,
So if we went to the Alachua County Health Department today and we asked for, 8 tests, what would we get?
You get the fourth generation test. Now, here's something that we didn't really talk about today, but we've talked a little bit about treatment as prevention. We've talked about how if you have somebody that is acutely infected, they're going to have the highest viral load ever because they haven't made any antibody to control that virus. So when Joanne's talking about the viral set point, that's kind of what happens after you have this big burst of virus. The antibody comes, and then the virus kind of chills at a level that person's probably going to have unless they get on therapy. And so with this program that's called Test and Treat, you can actually now
test somebody, when they test positive, you get that diagnosis and you send them straight to the health department and they can get right on interventional health therapy that same day. So there is progress being made. That's not currently up and running yet, but the state of Florida just bought a ton of drugs. They give a 30-day starter pack because our area is very difficult to get through the whole Ryan White funding process for people that don't have money. It takes like 2 weeks.
Care, and their goal is to keep them in care and not lose them.
So I don't know if any of you guys felt what Debbie was trying to get us all to feel about the fear, but that immediate reaction is a reaction that we have to react to. We have to say, whoa, you're scared, let me get you help right now. Instead of saying, well, here's a stack of papers for you, and it's going to take you 2 weeks to get your drugs. So this is where HIV care is going. It's getting better, and it helps people that might drop out because they're like, whoa, I thought I was going to die, and here I am 2 weeks later, and I haven't seen a doctor yet, but I'm feeling pretty good. I think that test was wrong. I would jump on it. Maybe we'll have a better chance of trying.
Where does health insurance factor into this?
So if somebody has health insurance, then they can potentially get to a provider, like if you have Gator Care, you can come see me the same day, and I will write you a script and we'll draw the labs that day. And we won't even wait for the lab results to come back. We will just put you on a regimen that has a high likelihood of success with a low chance of resistance, having a problem with drug resistance. But often health insurance has put up barriers. You have to do prior authorizations. These drugs are very expensive, even today. And so,
But the tests are covered by everyone?
tests are covered by Medicaid if you're, tested by a provider.
Medicare also, it's just you have to know the codes. Not everybody's great at billing codes, and so they'll get them returned back to them, and you have to have a very, strong constitution in order to keep going. Hey, you've got a task, the insurance company with this.
But it's easy. I've never had one denied. And what you do is you just put high-risk sex and exposure to HIV or exposure to STDs, and those are the billing codes. It's easy and epic because you can just type in exposure to HIV, and you'll get your code B72.
Will it still get bounced back as a prior authorization, though?
Not for the test.
Not the test, okay.
But the drug.
The drug, yes. So then what about a needle stick? Can you go through the needle stick protocol? Because I think that's also something that...
Oh, yeah. The needle stick protocol works really well here for occupational exposure to chance. That works pretty well. I don't know if you guys have gotten a chance to meet Ann over there, but she's like a rock star. And so that actually works pretty well. Sexual assaults work well. Non-occupational post-exposure prophylaxis does not work well. And that's because when you're a sexual assault victim, we have starter packs. The sexual assault teams often can get those drugs to you very quickly. A non-occupational post-exposure prophylaxis, like somebody that has sex with somebody in the condom breaks, is not a sexual assault. That's more problematic. Oftentimes the emergency room just kind of gives these people stigma when they walk in the door. And we know that post-exposure prophylaxis really needs to be started ideally within the first 2 hours, but you have to do it within the first 3 days or it's really not effective at all. So these things are
I
good issues.
brought that up just because last year I had a medical student disclose a needle stick incident that she was concerned about and didn't feel was being handled in the correct way. And I kind of reached out to Dr. Janelle, like, oh. And she fixed it all, which was awesome. But, even here, there is ignorance abound about protocols for needle sticks or occupational exposure. Even though, gosh, now when I look, I know where it is. It's everywhere. But somehow that message has not gotten across to even faculty in some places where you'd expect it to have gotten across.
And people kind of lose their minds when they get stuck. Like you can have a sign right in front of them and they will not see it. So
That fear, that terrible fear, and it freezes you.
Can I just, so I had a needle stick when I was a medical student, and I called the occupational line, and they made me collect blood on my own pension, like the patient.
like handle a needle.
Seriously, when they made me go and
Is that
collect
here?
blood.
Did
Yeah,
you get
so
it?
it's here. Huh?
Did you get it?
Yeah, they said, these are the, it was off hours, it was nighttime, and the person who was on the needle stick was a nurse in the emergency department. Okay, these are the two, you can go collect your blood.
Well, I'm hoping this is going to be different now because we actually do have a needle stick protocol, which we didn't have then.
Yeah, that was in, it was like 2011.
Yeah, and the emergency room has been very reluctant to really be part of this process, and so now the student infirmary does it.
Okay.
So if you're a Shands employee, it goes through Shands Occupational Health. If you're a UF employee, it goes through student infirmary. And they have a special phone that's just like needle sticks. If there's blood on hand, that gets processed. You don't have to draw it in unless there's no tubes. And I would certainly hope they would ask the person that just got stuck to get in the needle.
Again.
Because, talk about,
That's actually one of my cases.
Oh,
No. Just one question to pull it all together. Was there anybody that you thought at that time, were you thinking about, hey, there's somebody I need to tell about this? Did that even come across your mind as you're going through your tasks? Because a lot of people say, who are you going to pull in? Who are you going to disclose to it? Sometimes it seems like a little bit early because you're in the midst of it and you're anxious and so I always throw that question in there, is there someone you want to confide in? Would you have gone back to your partner, the person that initially affected you and said, gosh, I'm scared, I think that I might have something, or would you just blow it off?
Immediately?
Yeah. If you thought
how
that
the heck
maybe.
did this happen? What choice did I just make?
Exactly. And then I'll ask, what I do is when you open those envelopes, I'll ask the same question. Is there someone you want to have here right now? Do you want to have a partner? Is there a partner to call? Is that important to you right now? And is there anyone else that needs to be here? And then I use this as, let's do some counseling. Let's talk, what does this person need right now? Do they need us to be telling them this? Or do we need to sit back and say, here's the result. Let's sit for a minute and tell me what you are thinking right now. What do you know about HIV? And listen a little bit so that you know how to guide the conversation. I have found that when we do that, we often have an opportunity to, when we listen, we hear where the patient might need to be guided to go. If we give too much information, we may not be hitting that spot, that sweet spot, that maybe that difficult spot of them that they need to hear something about first, which makes all the other information we shared easier. So, if they need to say, hey, I know who this partner is, I'm devastated, I thought maybe this was happening, yeah, right? That's it. You want to make sure that you're going in there. Did you see that? I had her write this.
We were like, I don't know what she's like. I was like, I'm like, why?
I'm like, I don't know. She's hearing out for Does anybody have any questions about?
Can we look at our test results?
Yeah, we can. I didn't know if you wanted to do that. I didn't ask yet, so let's find out. It's certainly not the sweet state group. Sorry, I didn't. I had to handwrite it. We have relief, we have rats. So again, you get the idea, and sometimes it's helpful when you have students, especially interprofessionally, working together. I think it's important to get in touch with what these students could be like. Just remembering that some of your students or a student could be positive or had a needle stick, they could be sensitive to something. So you want to really be very, as you guide along, make sure that you're watching and making sure everybody's okay. And are you okay with this? You can sit down for a minute. Because obviously, maybe it's about a family member. Maybe it's something I don't know yet about them that has now suddenly touched them with a feeling because they watched this experience and participate. So just FYI in that.
I'll tell you that there's a couple of medical students that have risks. And, I went and I spoke to some of the medical student classes over the last couple of years, and invariably, in the hallway after the talk, they're running after me going, I just wanted to talk to you about, and people worry about this. They're very scared. They don't want people to know anything about them, but they're worried about their risks. And they may come and talk to you about it. So, be ready for that.
Right. And I normally would do that and say, if anybody has anything that they want to share medically or psychologically with me, something that happened to them that they want me to know about, please come. My door is open 24/7, essentially. So it's important because you're not going to be able to work with other people if you're hurting or you're remembering something that is traumatizing, whatever it is. We just never know what their experience is going to be.
And I'm just thinking, I mean, I felt comfortable kind of initial, but not being an expert in this area, would it then be appropriate to refer to you?
Yeah.
I mean, that's what Eric did, you know, he just said, hey, how's this work? And I said, well, I'm not the occupational health person, but let's make a link right now.
Right, yeah.
You know, we have to touch that student all the way through, because Eric could have said, oh, I just told Dr. Janelle, and then I could have called Ann directly, but instead I called the student to say, I got the handoff.
Yes.
This is my thing now.
Right.
And then Ann immediately called her. So those kind of, you know, people are scared, and we have to, it was funny today because I was listening to a talk that somebody was talking about efficiency in the clinic, and she kept saying coddling. I coddle students, I coddle all my patients, you know, because when you're in distress, that's what you need.
Exactly. So I think it's really important. One of the cases, and I think what I'm learning from this is that, you know, this is a really great learning experience, and it's even hard to rush it, you know what I mean, because there's a lot to think about, and there's information that needs to be heard, and questions need to be asked. But I had a student from Barry University call me, and this is one of the cases that I was going to go over with her, and she called and had a very bad situation. She was working in a clinic, and essentially this clinic physician said, I don't know how to treat this, but you're going to finish your shift, go 4 more hours, and then we'll talk at the end of the day. So her anxiety level, and she had known me from doing a presentation once, and she had kept my slides, and she found my phone number and called me. And so, and to make it worse, it was a holiday weekend, and so she had nowhere to get the meds. Her insurance company denied it. She didn't have $3,000. She had to borrow money from family. She had to tell them that she might be positive. This grew into this huge mushroom. So by the time she had me on the phone, she was sobbing. She couldn't catch her breath. And I said, where are you? Let's just sit down. You know, who's in the room with you? Who's in the building? You know, I was really concerned for her. And I called out a favor with a clinic that I know down in Miami. And I had one of the providers call her and see her. Because the school offered her no help, the pharmacist said, sorry, she's at 30 hours, she can't start the medication, and she doesn't know who the patient is. Because the sharp was sticking in upside down, and there was no way to know who the patient was. So she's had to go through the 30 days of treatment, or 28 days of treatment. And she was running out of time. She knew 72 hours because she had the guidelines because I had given those to her. She had the pocket card, and she's going, you know, she said she's shaking, and she's like, I don't know if I have the most recent pocket card, and you know, and so she was really, really struggling. But luckily I knew a DO, and she said, I'll call her right this minute, you know, but what could have happened to her if she was really in a panic mode. So just being aware of that, because that creates a situation where you're afraid of your patient in front for a new learner. And not having the backup of the clinic, not having the backup of the school. She called the school, and they said, we don't deal with this, go see your primary care provider. And this primary care provider had no protocol. So, you know, that, like you said, he did prescribe the right meds, but nobody had them. So she went to 4 pharmacies and finally found a mom and pop pharmacy to get one, and then she had to get the other one later, but she got them all in within 72 hours. But I'll go through a couple of slides real quick. And
we are gonna.
Yeah, and I'm just going to breeze through. I hope that was helpful and just, you know, interesting, because I think it's just a great way to learn. So we already know that stigma has a high, that stigma has been labeled as one of the most formidable social and psychological aspects of the HIV experience. Okay. An overview, a very quick one. I don't want you to get nauseous or have a seizure, but I will be going through these pretty quickly. So what is stigma? There's so many different types of stigma. There's anticipated stigma, not really having it yet, but you're anticipating it because HIV is stigmatizing. Or maybe you have a lifestyle that's different than those of most people you know, so you have added stigma. Experience stigma. Many people already experience stigma, so they already know what that feels like, and if they are experiencing HIV stigma, they're experiencing another level of stigma, more of what they already know. There's secondary stigma, which I have experienced secondary
because I used to work in the islands where I worked in HIV clinics. And when you walk through that door, everyone thinks you have HIV. That's the only thing they do there is treat HIV and STDs. So people would assume, and people would say, they would not want to eat with me or share food. And I had several people come up to me and say, "You're positive, how you doing?" And I say, "I'm not positive, but I'm doing fine, thank you." But I recognize that all of my patients were having this experience because they walked through the door that said, HIV, STD. No. There's internalized stigma that we internalize ourselves, and sometimes compounded stigma. Maybe we're stigmatized for other issues in our life, and so it becomes internalized, and we carry that around with us all the time. Then there's that compound and layered stigma, which might be many issues in our life where we experience stigma. So HIV may not be our biggest issue with stigma. It could be something else, like mental health illness. Then we have observed stigma. If I watch someone who's stigmatized, now I've observed it, and now I may internalize it because I'm thinking, oh, what if that happened to me? That's a horrible thing that just happened to her. Oh my gosh, I don't want that to happen to me or my sister or anyone I know. So that we call observed stigma. And you can actually be traumatized by something that you've observed, especially if it's been abusive. And then discrimination at one of the worst levels, where we prevent people from being themselves, and we prevent them from feeling accepted and respected. And that's the best way I know to describe that. So knowledge, the root cause of stigma is usually a knowledge problem. And knowledge is power. So the more knowledge we can have out there, just like what we did in our circles, we were sharing knowledge. And that helps people understand. It brings down levels of anxiety, which many of you shared with me that you had. And when we have fear and we give out fear-based messages, it creates anxiety and it complicates people's engagement and linkage to care. Another cause of stigma could be morality issues, and of course we see that. I see that a lot up in certain states, like in the Panhandle of Florida. We see a different experience for our individuals up there because there's such a religious commitment by people. And when I'm in the Virgin Islands, I'll have cab drivers just say, you know, what do you think about these guys that are going out with guys? You know, God didn't make the world like this. And, you know, and I'll get an earful and I'll say, no, it's too bad that we all can't just be more open-minded about, you know, and then, you know, I want to get to where I'm going. So I obviously, I'm watching very closely that we're not taking any back roads. So you have to be careful. You have to, you know, sort of balance yourself. But there's the karma effect, like if you are a good person, good things will happen and bad things won't happen to you. But there's this schematic of innocence to guilt continuum where, okay, if a child has HIV, it's not their fault. So we're not going to stigmatize a poor child. Okay, now, again, I'm throwing these terms out. A poor, innocent child that would become HIV, that's not their fault. So we're not going to throw a lot of stigma at a child like that. And as you move more towards this side, they're guilty. So someone who's uses drugs and injects them, or sex workers, might be treated terribly. And in the Virgin Islands, if you're a sex worker, you would get no care. If you walked in and said, I'm a sex worker, they would basically say, we're not touching you, you need to leave. This is in the health department, the only place that someone could go to receive care. So if you sort of see that this is another way of looking at how stigma is develops and how it sticks, I think, would be the word. The National AIDS Strategy, which Joanne went over beautifully, it's still an epidemic, and stigma is something that they've actually addressed in the strategy. And I'm going to point out exactly where it is. Every person diagnosed with HIV deserves immediate access to treatment and care that is non-stigmatizing, competent, and responsive to their individual needs, cultural needs, spiritual needs, every kind of need someone has, holistic kind of care. And it's written in there now. It wasn't always like this early on, but now it's very clear what needs to be done. The goals for the the national strategy is that we want to increase access to care and improve health outcomes for people living with HIV. That's the most important thing. If you're talking about stigma, that part doesn't get done enough because stigma gets in the way. And we have to come up with interventions and strategies. And there's money going into it, but it's not happening fast enough. We want to reduce HIV disparities and health inequities, of course. So HIV-related stigma, prejudice, discounting, discrediting, discrimination. The goal 3C in the strategy is reduce stigma, eliminate discrimination that's associated with HIV. Stigma and discrimination must be eliminated. The strategy is just all over it, and we never saw this before. It was in this 2020 strategy that we're seeing so much about stigma and individual care, holistic care. So unfortunately, all of our patients many who are HIV positive also have other stigmatizing conditions going on for them, which may be actually at a higher level of importance for them and maybe even more defeating in terms of who they are and not being able to be who they really are. And I'm going to pass that, and I have those two things, and I'm going to do that. How do you measure stigma? Well, everybody's trying to measure it. There are tools out there, and I have been through a lot of them, and some of the team that we've been working together, we looked at them. There's a lot of work going into identifying student stigma, because we know that if students have stigma going in, that it would be nice if we could address some of their issues before we put them out there in the work world, in the learning mode, so that they can not bring that with them. But they don't have it right yet, because there's so many compounding levels of stigma. If you look at HIV stigma, you would also have to look at sexual orientation stigma and religious stigma and all other kinds of economic stigma. So it's really we're hard pressed to find something that works yet. Puerto Rico did a great job, and they put together a huge stigma scale, and they're using it with all their students, and they have an IPE program there at the University of Puerto Rico. And they're very successful with this one tool that they're using, and it looks a lot different than the tool we've all been looking at. So again, I think, we haven't gotten it all there yet, but there's some good questions in all the tools. So we want to really measure, we want to assess, train, and sustain with our students. Okay. The language is important, and if I could just impart on you to do anything with your students, it would be to change some stigmatizing words that we use and change them to something that's more preferable and less judgmental. So when we say mother to child, what are we insinuating there? That a mother has given HIV to her child. Oh my goodness, that's a big burden for a woman to carry with her. But if we say vertical transmission, we're lightening that a little bit. We're not saying, Mom, what did you do to your kid, because women have trouble with this. And that's why they stay out of care. We're having a real hard time with moms that are HIV positive who have babies who are positive to stay in care themselves. They bring their baby in for care, but they don't come to care anymore. So that's a problem, because that's a big guilt and a huge burden for them. Promiscuous, that's a value statement. What if we say multiple partners? That's a much better way to say that. HIV, AIDS, use HIV when appropriate. Don't say AIDS unless you mean AIDS, okay? And there's a definition for AIDS that goes by CD4 count and some of the other conditions that would show themselves at that time when someone's CD4 is that low. Compliant, we don't want to use that word anymore. We don't want to make someone look like they're stubborn and non-compliant. We want to use adherent. Not adherent to the coming to appointments, not adherent to using meds, not adherent to other things. It's a better word to use, less judgmental. And victim. We don't want to use the word victim because a lot of these people are survivors, and so I like not to use that. And if I'm using the word victim, I'm talking to a policeman or somebody in some sort of court of law. But when I'm talking to an individual or about an individual, I don't like to use the word victim. So just those little watchwords I have for you. And in summary, recognition of stigma and discrimination in healthcare settings is limited. A lot of it is unconscious. Not everybody is conscious of some of these stigmatizing thoughts and behaviors that they have, and they don't realize it. So it's nice if we can sort of catch each other. And with my students, we had a word. I had the students come up with the word in clinical, so that if there was somebody that was perhaps using judgmental language or looking like they were being judgmental, anyone in our clinical group could call. It wasn't just me, the instructor, it could be any student. And we had a word that no one would, like, I love dogs, or something like that. And it sounded a little weird, but it was a watchword for us to be checking ourselves, to help each other out. And it wasn't a negative thing. Students in the beginning said, oh, I don't want to do that, I don't want to do that. And I'd say, hey, I said I like dogs, and I was surprised that I was the first one to come up with that. And they'd say, well, we didn't want to call her out. I said, it's not a call out, we're helping each other. That's what interprofessional education is all about. We're helping each other be the best we can be so that we're there for our patients. So that's it for me. Thank you for letting me rush through it. I had some cases, but we can use them in the future. I can work them into motivational interviewing and a bunch of other things. I think the early exercise was really valuable. Yes?
So I thought the language of HIV was interesting. So we have a substance use disorder program, and we talk a lot about these things too, and not to copy the things we have. But I thought that adherent didn't seem much less stigmatizing than compliance.
Well, the compliance was used very originally in HIV medicine for a long time. In fact, if you go back to the movies, if you followed any of the HIV movies, was it Cowboy, what was it, the one? Dallas, they used the word, you're not being compliant, you're not doing what we're telling you to do. And he was already feeling victimized, and he was already feeling bad about himself. And so we had to come up with a different word. And so you see adherence used pretty much throughout the literature. I think there are probably better words that we could use, but I'm not going to change adherence. When I see a patient and we're talking about coming in for regular care, and that's one thing we really like to do now, not just talking about being adherent to medication, but coming in for care. Don't leave. Keep coming, and if you're not going to come, tell us where you're going at least. We don't want to lose track of you because we care and we worry when you don't come back. So I use those kinds of words as opposed to saying adherent to coming to your appointments, because it seems so school-like, or something that you're being dismissed because you're not doing something right. And I had this amazing conversation that I'll end on with a long-term provider on the phone yesterday, and she said she has patients that sometimes she hasn't seen for years, and she gets them back into care, and too many times the provider who brings them back into care says, where have you been? We've been looking for you. You haven't been coming. You didn't do this. You didn't do that. And she said, why would they want to come back? So what she does is she says, I treat them as though they walk in. I say, how have you been? I've missed you. And she says, I treat them like they were here the whole time. I treat them without a judgment about what has happened in the past. I just say, hey, we've missed some time with you. Tell me what's been happening. As opposed to going in the back and saying you weren't doing this, you weren't doing that, but accentuating, you're here today, I'm excited you're here, and let's have a good discussion. So I think that was a valuable thing. She's been in the field for like 50 years. Thank you for your question, comment.
On the logistics of the session. So what we wanted to kind of do was simulate a little bit what our students will be asked to do in part when we have our IPLH session next week. And I want us to get into two groups. We're going to kind of really quickly, maybe even at the risk of being somewhat superficial, kind of simulate the application exercise. So people can just count off 1, 2, 1, 2, sorry. Two groups. 1, 2. 1, 2. Okay, no clutter. So, good thing is we've got some space. So if you can bring your IPLH facilitator guide, and you also going to have the worksheet
Yeah, and the worksheet.
and your root cause analysis worksheet.
And just as an FYI, we've already found, although this is a draft, your facilitator guide, there's an error in there, it won't affect anything. But
But maybe the ones over here and the twos over there, and kind of get, I know with tables, kind of get situated so you can work together. Now, twos are over there.
Oh, I'm just, oh, that's right, I was.
And ones are over here. Try to get a tennis situation.
come on over.
Okay. So, again, Eric will go through, or you know, if you've got questions later, more of the specifics of the particular IPLH format. But what we want the students to spend some time doing is reading the case about Morgan Rivera. It's on page 9. So when we go to the facilitator guide, page 9, and essentially, as an individual, read the case about Morgan, and then read your task. And as you're now in an interprofessional care team, start doing the task, and you may want to refer to your worksheet, which is basically going to ask you to do a root cause analysis and begin to identify problems that occurred in her care. So we're going to do this pretty quickly, so maybe a quick read, and as soon as you can, as a group, start talking about the case and identifying issues. I'm going to see where people are in about 5-ish minutes.
Hey, Amy, maybe if we could just focus on sequence of events, which is 2.1, and then
I think if we can get there, that'd be great.
I think just going sequence of events.
Yeah, just kind of see, this is not a contest to see what group got farthest or. No practice? And there is not necessarily a single correct answer.
Yes, it's cluster of differentiation form.
Somebody who doesn't know.
Doesn't know anything?
What language are you speaking?
All right.
You guys are ready to start discussing the case.
Yes, we are discussing the case. All right, y'all.
Okay, so if you guys.
Oh, actually, I guess the first question.
And get together and start talking about your task is really, I mean, we're a quality.
Well, disaster hospital, because people like to,
Look at
yes, I
those
heard.
situations when test information
And what harm result?
related to the patient's history has popped up. So, usually for the hospitals, which easily covered.
she can get that, I am making sure.
But it's not, and you can see.
Yeah, but they didn't get a referral when they were, I guess they didn't, you guys, I don't know, that was a little bit confusing on the sequence in the case. Because it said, post office also put up the case, so there was no referral to ODAC. So, yeah, where was she supposed to go? Because they show that she knows, oh, but, yeah, maybe,
Or maybe it didn't go in the discharge summary, even though knowing the way that,
Okay, so no written referral was made. It says it was with orthopedics and, should I say, and OT and PT?
well, you say specifically in here though that there was no written referral. So that, I think that was intentional work.
yeah.
I think that's appropriate, I think that needs to be.
That's probably too subtle for these students. They're not gonna pick that
And
one up.
just take it out.
We'll keep it, we keep it just because, we like to mention every profession. If we don't, we get. Like audiology. The question from Friday, is there an audiologist? Please. There was a, okay, so there was a, thank you. No, we're just gonna change, there was no written referral, to there was a written referral, this was never actually published.
Never did it.
Okay.
So when she initially came in for the.
Oh, there's some, we'll fix that stuff. Okay, so, we established that, what else we got, lots of functions, PCP. For oral health.
Insurance team.
And that's something that I like for.
Do we look at the incidents where
I
she
did
came
not
in?
know that.
You're unfunded.
At what level, So I don't
It will be clean and expensive. They won't do
They reimburse at Medicaid, Medicare.
I don't know whether the contract, they have dental centers that have accepted their, so,
Wow.
or they'll pay some, I've seen them say.
She would have been there.
But I don't know if they want her. That's in part of the. Yeah.
That's good to know.
In
All
our
right.
area, I mean, private principal from the Foxes.
So let's talk. That's good. Anything else that we?
So if you've got a correction, that you
So I was just, that's maybe what I have done in
in the story.
Yeah.
We haven't even add that in Joanne, I'll get that there.
So continued substance use,
And it
abuse.
didn't look like it was addressed. Yeah, I think it was when I thought.
Yeah, well, at least we.
Multiple persons.
I mean, she was provided a prescription for opiates.
Yeah, I thought.
And then they go down by.
And then she missed all the stigma.
And she came in with.
Ah, yes, okay,
So
so
when
we
we gave
got
this opportunity
mental
to
health.
back to that. And they were originally like that, she was making that rush, which is an time that would have prevented.
And you have a new diagnosis of HIV.
It might be different DNA, if you see fresh DNA, that might be okay. To the, from the health department.
Right.
But think about now, what did they do differently with your point, with respect to her
So
follow-up?
they, if they didn't get the correct part, let's say people found it was 98, so, what's the point of checking this out if you're not going to do something about it?
Maybe I'll pick that up, it's be specific.
Because they actually made.
So
they
let's
made
talk
her
about what was the
repeat it.
sequence that was
Appointment.
expected to
Gave
take
her the
place, what was
appointment.
going to happen.
And for the HIV, she was
What-
going to be discharged. A referral, for her to follow up, right?
Correct.
In a magical world, I think the perfect answer is for someone to list the HIV. Now, obviously, there's other stuff going around here, right? No. So obviously, there's other stuff going around here, so it would be great, but what I would be looking for would be, oh, that continuum care thing, it's 5 steps, right? Or, or 4 steps, actually. Yep. And then for them to understand that uninsured, what terms uninsured, are there resources for uninsured people?
If she's uninsured, she's had this hand injury, and she's got an AIDS diagnosis, we talked to the social worker, and her,
Well, we don't have a social work school here, so that's.
Okay, so the other thing, the other issue, if she was on.
Tomorrow, you can work on that.
Yeah, so she got into the charity care program, she could have got, so obviously, she got to work with you somehow, if they did follow up. So that was charity care, she could have gotten charity care.
There was, there was no, the other one, there was no, inter-team communications. Ortho, team did not.
Well, the other thing that happens when people go to the health department, they announce their ceremony.
Right, stay in the lane.
And so.
Okay, I'm gonna call time, just because we're gonna be respectful of your time. I think we may have found a few typos or things we want to clarify in the case before we can still do that, right?
Of course, yes, please send all papers my way.
A couple hiccups here. But hopefully you all got a feel for what we're gonna be asking the students to. If we had more time, we would have actually continued to discuss what, I'm hoping we're actually discussing, we're beginning to discuss kind of what didn't go right with her care. And hopefully you're picking up on the fact that there were multiple things that didn't go right with her care. And did anybody identify that there might have been multiple professions involved? That's the interprofessional part? Yes, clearly. My understanding is that our Morgan is actually based somewhat on a real person. A little bit, yeah. A little bit. A little bit, but then there was obviously some creative license there.
Names were changed.
Yeah, like 3 or 4 people.
Yeah.
Right.
Oh, she's got a broken, or my husband did that with cocaine one time, fell off the horse, yeah.
But the idea that this is not necessarily totally unique, you know, but totally answerable person. So, again, watching the time, the idea is this is what your group's going to be doing, making this case and then working through this root cause analysis. We will want somebody from the team, from your team, and it'll probably be in about sizes of 8, even 9.
I think we're aiming for 7 this time.
7, okay, then they will have students from different professions on them, turn in their root cause analysis worksheets, so.
Just 1 per team. Now, there is space up there for RTA team members, team member and team leader. This is a challenge. So you can emphasize several times, put your name on things, that makes life easier. Probably not before this one. We're gonna show you guys the video before we shut down tonight.
Okay.
One thing I want to emphasize, because you guys are kind of, with one exception, Nicole's done this before, kind of flying a little bit blind. That's okay. So everybody here who's never done this before is going to be paired with an experienced facilitator who's kind of experienced the managed chaos of this type of thing. And it really is managed chaos, and that's okay. It's supposed to be. All right. The objective is not necessarily for the learning to happen in between what we call inter-team, the learning happens intra-team. The learning happens in places where you're not going to hear it. So don't obsess so much over the fact that, you know, maybe it doesn't look like what you thought was going on. I think part of this is just understanding and relaxing and letting the students do what they're going to do.
They're gonna learn from each other. And every group is gonna do it differently. And they may learn some stuff from each other completely unrelated to this case.
And that's good.
Which is actually okay, because we know they're going to be learning about HIV from all the other materials, and if they've read this in part, I know they're going to learn something from this case. But in terms of that interprofessional, it's just going to be that sharing with each other. So.
Yeah, and at this stage in their training, none of them are really equipped to do this at all. You know, if there was a right-wrong type thing, you know, they would not do well on it. That's okay. What we really want them, and I was talking to this group, an ideal solution to question 2.1 is just for them to lay out the 4 points that the care continuum. What if they did that, I'd be ecstatic. Not that exact same slide, but if you go back through there, in the facilitation guides, you will see a handout that describes the HIV care continuum.
Right, page 28.
Yep.
And I'll just argue, if you want to show that video ahead of time, I think that this patient is going to turn some people off because she's just like that extreme. The patients that had to measure that way because of all the medical problems she has to have. But my feeling is people are going to go, this is just what I thought these patients were going to be like. And yeah, right. And so the video to me will say, you know what? Some people have times in their lives where they're like that, but you don't have to stay in that same situation. And you know, I just thought I'd do a shout out about that.
Yeah, and I think it's a great point. And again, as facilitators, this is one patient. It is fictional. We're bringing some things up, and yet there are some things common to this person that may be common to people who don't have HIV/AIDS. You know, history of abuse. Actually, as we progress with Morgan, her history of abuse and everything will be very salient, really in the second and third sessions, as we do start talking about average childhood experiences and trauma informed care. I did not say that one equals the other, but to just heighten student sensitivity that people are coming in with all sorts of things going on.
Let me just be democratic about this though. So let me show you, this is I know we are right there, I want to be as respectful of your time as possible. One of the challenges that we've got here in Gainesville, while HIV is a really big issue, we don't have access to a ton of patients who've got HIV in a way that conforms to the things that we do here. Obviously, we would love to parade 700 students through Dr. Janelle's clinic. She probably would not enjoy that, nor would her patients. So one of the things we did was we went out and worked with a couple really wonderful individuals. No, we've had those for a while, but we officially have them. Sorry, this is now not responding. If you give me 4 minutes and then you give me a should we do this or not, I will make sure that we've got the ability to do this at some point in there. Hello, you gonna go?
I got raped, and then I got shot. And the bullet went through my right eye, come out the back of my head. And when they found me, they pronounced me dead. They covered me up on the side of the road. And I was taken by helicopter to the hospital. There, twice on the table, my heart ceased to beat. So they had my family prepared that I would never be able to function normally. There was a therapist, there was my physician, and a few more people came in, and they proceeded to tell me that you know, from that incident that I was checked for everything, if you name it, I was checked for it, and that I had contracted the virus.
I went to a health clinic. I had like a flu-like symptom, and so I had to go draw my blood, and I remember thinking the whole time, God, I don't want to go back for that result. I just don't want to go back for that result. So I don't even know how I walked to my car. I don't even think I was even conscious of where I was walking. So I think I was in shock. You know, I felt I was just in shock. I didn't really, disbelief, you know, I just, and then the guilt kicks in, you know, you just say, oh, God, I screwed up, you know.
When the doctor came in and gave me the diagnosis that I was HIV, I've never met this doctor before. When he would shake my hand, look me in the face, and tell me that I had to change my whole life, or, you know, eventually I was going to die from this. And that scared me. I'm just as human, I believe, just like everybody else. And them to put a stigma in front of them and me because I'm HIV positive, why am I so different? I'm not any different than anybody that has diabetes or problems with their heart. They take medications for high blood pressure. I'm no different than that. I just have a disease that if I don't take my medication, I'm going to die.
The worst thing in the world would be for someone in the doctor's office to be rude to someone who's first diagnosed and come to the building, and then, you know, they're not going to come back. They're going to go find someplace else, and then they take them years to do that, and they could get sick.
Don't assume you know how this person ended up with it. Don't look at the fact that they're living with something for you to kind of like draw a conclusion of their life.
Some of your actions, some of your pronouns, your microaggressions. In a first meeting, it really hits hard on people. We're scared as it is.
If you don't feel like you can respect a person living with the virus, then you're in the wrong. That's the wrong job. You shouldn't be working there. I mean, you respect them as an individual. You know, you don't label them. You make them feel important.
I just want to be treated.
Pretty much. I only wear blue shirts.
Who has my best interest in mind, and that they know what they're doing, and that I can rely on them when I need to.
You study medicine for a reason, and to help people. And all we're doing, people with HIV are asking for help. That in itself, if you can provide that, is the best medicine.
So what we realized was that, you know, obviously our students really lacked the continuity to get to know someone who, you know, was positive, and this was kind of our Hail Mary to see if we could establish a relationship, a connection with, you know, 3 different fabulous individuals who were, you know, show this or don't show it? Tell me. Yeah. Good. All right. Probably.
We're past time. Thank you for coming. Eric will send out further instructions. You can kind of read some of the other logistics for the IPLH session next week, but as he said, you'll be with an experienced person if you haven't done this before. We wanted you to get not only the wonderful content, thought-provoking, how are we teaching this, that stigma, but also a feel for that application exercise.
Mm-hmm. I got you on my schedule, don't worry. Don't worry.
As I said, we'll be learning more about Morgan.
Mm-hmm.
Any other
No.
questions? Be safe.
Thank you so much. I'm sorry we ran over time. Yeah.
It starts getting worse Friday-ish.
today.
Huh?
Thanks for being willing to invest with me.
Oh, no, I think I didn't even